Uh, so we are, some of you are going to start your hands-on training program from April 1st. Mm. So we had sent two documents. One is for writing the patient's, just a brief about the patient diagnosis, what were the symptoms and what medications have given, and what were the learning points. So we can actually ask you to write maybe 2 pages on the patient, but we don't want to do that because it's up to you that you should understand the symptom management. So that's why it was made short. And another one was on procedures. So many of you might be doing many procedures, as well as you might be an expert in many things. But we have charted out a few procedures in the second Google document, which you can, when you observe or if possible, you can do, but uh, I think you may not get a chance or may get, I'm not sure. So whenever you observe the procedure in that Google sheet, you just uh, submit the procedure that you have observed. So you can do it in every day if you have observed a procedure or anything that is mentioned in that Google sheet. It is mainly about procedures and things like syringe drivers, subcutaneous infusion, etc. But other document is on patients you have seen. That you have to submit every day. And you also has to remember that you have to take a long patient story, which you need to present, and which would be the mark of which would be taken for a global fellowship examination. So when you get a hands-on posting for 1 month, please take a long case history, which should include all the aspects of palliative care. So it is needless to say that you have to go through physical, psychological, social, financial, spiritual, all those aspects, covering all those aspects, and management as well as follow-up. Follow-up is more important, and then you can also reflect on that patient. Um, so we will send the details, but please keep it in mind whenever you see a suitable patient for presenting to the examiner. Please take this patient story. So those were a few things which I wanted to remind you. And yes, Vineetha.
Sir, when we will have that exam, sir?
Global fellowship examination will be in December.
Should we come to Trivandrum for that, sir?
Yeah.
We all of us will have a single date, sir, for exam.
Yeah. Everybody will be coming on a single date.
Okay, sir. You will announce the date maybe sometime in November or something. You will tell us.
Yeah, definitely. But it is in the December. That's also.
Okay, sir.
I think Sunil sir is looking for some strict invigilators date. And once that is confirmed, he will announce the dates.
Probably Sri Priya would be the one.
And I will make all of them be with us for at least 3 months more, sir, because now I am so much used to seeing them, especially when, in the late evenings, when you get to see so much smiling faces, so much energy in people. Of course, we would love to have them always with us, sir.
Priya is listening more classes than us, sir.
Yeah, definitely. So that's why I say that Priya is now becoming a doctor.
Sir, will there be grace marks for people above 50 or 60?
I think those who are above 60 would be scoring more. They need not get a grace mark.
Because we are competing with the people like Parul and all the youngsters.
No, you have only white hair and mustache. That's all.
No, sir, with a
Doctor
wide
Vijay
experience.
wants to hear that epic
Yeah.
dialogue, age is just a number. So I have said that.
You're most experienced.
With a lot of experiences also.
Experience, sir.
Yeah.
I hope
Who is
it
the
counts.
senior most? Who is the senior most in this group?
Ashok sir, I think.
Association. Okay.
Parul wanted to ask something.
Yes, sir, I have a query. My concern is the language barrier with when I'm going to come to Kerala.
Same here.
So should I start learning Malayalam?
How can you learn in such a short time? Same language barrier
no,
is there, of
if-
course.
Yeah, definitely it will be there. But if you can learn something, it is good. But I understand that Malayalam is one of the most difficult language to learn. That's what people usually say.
Parul, what you can do is you can join with people who are there in your group who are Malayalis. That'll be easy. So
I have many juniors and friends who are from Kerala actually.
yeah, so you can manage.
Okay, sir. Thank you.
And
I can
of course,
see-
you can look out for my face and Sunil sir's face. We will always be
Yes.
there.
Yeah.
Definitely, Shritya. Thank you.
But when you go with somebody in the institutions where you are posted, there will be somebody who will accompany you. So they will be translating it for you.
Okay, sir. Thank you.
I think Vineetha has joined.
Yes, sir.
Okay. So we will move on to the second part of PIL, and I hope you got a chance to go through the first part, which was taken 2 weeks back. And at least, as we said earlier, the yellow flags, red flags, and some introducing structures and where would be the pain, etc. That will give us somewhat close to a diagnosis. So I think everybody knows Vineetha, and this is the third session that she is going to take. So I think without much introduction, I would ask Vineetha to go to her presentation. Vineetha, it's over to you.
Yeah, good evening, sir. Let me share the screen.
Yeah, okay.
Is it clear now, sir? Is it clear now, sir?
Make it in the presentation mode, Vineetha.
Yeah, I'm making it. Taking some time. It is visible, right, sir?
Yeah, yes.
Okay. So I hope everybody can see my slide, and I'm audible also, right, sir?
Yes.
Okay, so good evening, everyone. So this is the second part of our non-cancer chronic pain schedule. And I think by now everybody knows why this topic is being taken. Simply because of two reasons. One is that in cancer patients also we see a lot of non-cancer chronic pain conditions. And in my last class, in the first slide, I told about that. If you look at the incidence or prevalence of chronic pain syndromes, that the prevalence in cancer survivors or patients with a cancer diagnosis at some point of their lifetime is much more than the general population. And second reason is many of these chronic pain patients, they are very difficult to treat. So they come to you, pain physicians or pain and palliative physicians, with a lot of expectation. And many physicians will refer to you because they cannot do anything more. So you will have to deal with these patients, and it will be difficult for you in the beginning. But there is no way we cannot. They have many people have already shuttled them, so we cannot say you go to another doctor. We have to manage. So that is why we should know the basics of this non-cancer chronic pain. So I will tell what all topics I'll cover in the second part. First of all, sorry, I had a very busy day today, so I just reached back home, and I had a very tiring day. Sorry for the delay in starting the class. So So just one case scenario. This is also a revision of what we learned in our first class, but this is a cancer patient. Okay, so this patient had come to me almost 1 year back in the hospital where I'm working. So this patient is a 68-year-old gentleman. He's a known case of CA prostate, diagnosed 3 years back, and he completed chemo, radiation, and surgery, and was noted to have extensive skeletal metastasis, pelvis, femur, lumbar spine, skull, in a PET scan taken 6 months back. So he is on zoledronic acid therapy and completed 3 cycles of palliative RT, including the spine. The last RT was almost 3 weeks back when he reported to me at that point of time. So he had complaints of severe low back pain since 6 months with no response to morphine. Morphine was started by a pain and palliative physician in our hospital only, but another person. But there was no response to morphine, and there was no response to RT also. There was not much response to RT. There was some transient relief with paracetamol and NSAIDs. But obviously NSAIDs you can't take it for a long time. Then the pain is paramedian, as you can see in this picture. It is not midline pain, it is paramedian pain here in this area and in this flank region. Dull aching, no radiation, no neuropathic features, and right was more affected than left. And the pain worsens on position changes, turning in bed, standing from sitting, then lateral bending, etc. He is comfortable in the supine position, and sleep is not affected, and he was able to walk also. The maximum pain was in position changes. And the right side, the pain intensity was 8/10, and left side it was 3 to 4/10. And on examination, there was no midline tenderness, but there was paramedian tenderness in this region, in this paraspinal and in this flank region. His SLR, I hope you remember, straight leg raising test for radiculopathy. SLR was negative. SAJ, sacroiliac junction, was free, no tenderness, and all the tests were negative. And facet was also negative. The facet manual extension and lateral bending, if you remember, that was also negative. So my question is, what could be the possible pain generator here, and what else can you do for management? So anything else you can, because you all, not you all, most of you or many of you are already practicing cancer pain. So any idea what could be the pain generator? Last class we studied, it can be the disc, the vertebral body, the muscles, the joints. So what could be the pain generator here, and why it is not responding to morphine?
Muscle stress.
Yeah, who was that? I didn't get. Who was that?
Dr. Ravi.
Dr. Ravi.
Yeah.
Yeah, you pointed it correctly. It is muscles. Okay. It is, you told muscles, right?
Yes.
Yes. Okay. But not necessarily spasm. It is not spasm, but it is, what do you call that? That is a topic, our today's topic. One of the topics that I'm going to cover today. Myofascial pain. Okay. Myofascial muscle spasm is an acute term, something that happens acutely. But when it becomes chronic, it is myofascial pain. So why do you think this patient is having myofascial pain? Anybody?
Yes, you told about this altered biomechanics of the spine. He
So
had
why the
lumbar.
biomechanics is altered here?
Because of lumbar spine mets, he
Very
will
good, very
not
good.
be
Yes.
moving his back much, or he will try to stiffen his back.
Yes, correct. So that is correct. Whenever there is lumbar spine mets, or when there are multiple level fractures, the normal mechanics get altered. Usually what gives support to our muscles? This bones give support, that bony framework gives support to the muscles. When the bones become weak, the support is lost. In simple words, that is how you can explain. The support is lost. So the muscles are prone to more, micro trauma or injury. So that results in, when it becomes chronic, it results in myofascial pain syndrome. So here, the important point is this word, paramedian. Suppose if the patient was having pain in the midline with midline tenderness, what is the cause of pain? It is a METS, or maybe pathological fractures, compression fractures, pathological fractures from the METS. But now, since it is paramedian pain, that also that worsens on position changes. Because again, we are not sure, because there is no investigation that will point to you that this muscle is damaged. But clinically, myofascial pain syndrome is a diagnosis. And which muscles come here? Here it is the iliopsoas muscle, this vertically. And this flank pain, I explained in the last class. Which muscle comes there? Flank.
Obturatus.
No.
Piriform.
No. Piriformis is in the gluteal region. Yeah. Quadratus lumborum. Okay. So QL. So this patient, how did we manage? Because already my pain and palliative colleague was giving morphine, paracetamol, and other thing. So he was sent to me for anything else you could do. So I gave him this ultrasound guided 2 sittings of iliopsoas and quadratus lumborum trigger point injections. These are very deep muscles, so we cannot do it blindly. We can do it only under ultrasound guidance. So after two sittings, the patient got around 60-70% improvement in this myofascial pain, and the rest was managed by my palliative care physician. He had some symptoms also, but anyway, this particular back pain of him, why it did not respond to morphine? Because it is muscles, bones, they will respond less to morphine.
Dr. Vineetha, did you see anything abnormal in the muscle, or the trigger point was just clinically
actually, we will talk in this class that ultrasound, especially the normal ultrasound that we use, there will not be anything, any structural change that we can see in the muscles. It will look only sometimes tendons, if it is involved, it can be clearly seen in ultrasound. The tendons will be thickened, hypoechoic, but muscles, it usually will show the normal fibrillar structure. We will not be able to appreciate any changes.
Okay.
So this is the second case. So one topic that I will be dealing today is myofascial pain. That is why I gave that scenario. The other topics, it comes in this scenario. The 56-year-old lady homemaker, known case of CA breast. Okay, post chemo radiation and surgery, she complains of burning type of pain in the surgical site in the chest wall that radiates to the back since 6 months. And this pain started 2 weeks after her surgery. And after that, it is continuous pain is gradually increasing. And it worsens on touching the area. She is not able to wear her nighties or anything. And also an exposure to cold. On whenever she puts fan or AC in the room, that also exacerbates her pain. Her pain score is 7 to 8 out of 10. She is on tramadol 50 milligram TDS and pregabalin 75 milligram BD. And overall, the pain relief is not satisfactory. And she also complains of another type of pain, which is a diffuse body pain affecting the arms, legs, and low back. No neuropathic features. On and off headache also present. She's having poor sleep and she always feels anxious and lethargic. Her pain score for this type of pain is 5/10. The other one was 7 to 8 out of 10. And she takes paracetamol for this diffuse aching pain, not much relief. So on examination in the chest wall, that surgical site, she had hyperalgesia, allodynia in and around that surgical site. And she had multiple tender points in the arms, thighs, low back, and calf. So you can tell me what are the diagnoses here? It's a very straightforward question.
There are two components of pain here.
The initial first half looks like neuropathic pain. The one initially what you have described.
Yeah, what kind of, why is she having a neuropathic pain?
Entrapment neuropathy.
Pardon?
No.
Nerve entrapment neuropathy.
Yeah, post mastectomy. Yeah, this is also known as chronic CPSP, chronic post-surgical pain. One cause for CPSP is nerve entrapment following surgery, and this is one of the notorious surgeries that causes this syndrome. You see a lot of post-mastectomy patients with neuropathic pain in that area, in the incision site. Second part?
Fibromyalgia mostly.
Fibromyalgia.
Again, why fibromyalgia in this patient?
Ma'am, there are so many stressors here, triggering factors that can cause and predispose the patient to fibromyalgia.
Yes.
She's a known case of stress.
Yeah.
With
Again.
Post-chemo and something.
Yeah.
Multiple tender points. And
yes. You're true that it is fibromyalgia, but why fibromyalgia in this patient? Again, you have to go back to this diagnosis. CA breast and mastectomy. There is, if you look at the literature, there is a higher incidence of fibromyalgia in these patients. Okay, among cancer patients and those who undergo surgery, again, this is a notorious surgery, mastectomy, for causing neuropathic pain, for causing fibromyalgia. Okay, that along with whatever Dr. Parul said, the stressors, all these again contribute towards the development of fibromyalgia. But you should know that it is the incidence is more in breast cancer patients. Okay, so these are the conditions that I will be dealing with today: myofascial pain, fibromyalgia, neuropathic pain, and a little bit about CRPS. Because CRPS is one condition that everybody will say, okay, I am done. Now you go to a pain and palliative physician or a pain physician. So you should be knowing how to manage CRPS also. Okay. Now, so first we'll go to myofascial pain. So what is myofascial pain? So it is defined as pain of muscle and musculotendinous origin. Recently, the fascia is also gaining some importance. It can arise from the fascia also. So it arises due to trigger points. It is often perceived as deep and aching, and it is characterized by local as well as referred pain. So I'll ask a very basic question here. What is the difference between a referred pain and a radicular pain?
The radicular plane is along a particular segment.
Particular segment, or you want to be more correct? Particular?
Dermatome.
Dermatome. Correct. Particular dermatome, and then?
Whereas a referred pain is not confined to one particular dermatome. There can be pain originating from one place, but the pain can be perceived in other part of the body as well.
So in myofascial example is that suppose suppose the original muscle that is involved is having an innervation from C5. So other muscles which are innervated by C5 will also have show pain and sometimes tender points. So that kind of this happens in specifically in myofascial. Referred pain can happen anywhere. Referred pain from viscera can happen. In myofascial pain, this is one kind of referral. The muscles innervated by the same nerve root. So those we can say myotome, something like that will show this referred pain. Then, so how do you diagnose a myofascial pain? So it is basically a clinical diagnosis. So you will see a lot of diagnostic criteria in the textbooks and literature. So a recent, Delphi study in 2018 So they concluded that one symptom and 2 palpatory findings are enough to diagnose myofascial pain. So what are the 2 palpatory findings? One is a taut band within the muscle. Okay. Second is a hypersensitive spot within the taut band. A taut band and a hypersensitive spot within the taut band. And the patient should have referred pain, not just the local pain. The pain should, because if, for example, trapezius is involved, I'll show the picture. There is a common non-referral pattern for trapezius. So these patients will show reference along that pattern, referral pain along that particular pattern. So these 3 are essential for the diagnosis of myofascial pain syndrome. Then there are some other features like reproduction of patient's pain. I somehow firmly believe on this particular point, that in my everyday practice, I ask, is this the kind of pain that you are having? So that is an important diagnostic clue. Local twitch response, this you get sometime. That is the taut band, especially when you prick with the needle, that taut band will contract. Not that the entire muscle will contract, only the taut band will contract. That you will see that that is an objective sign that the muscle is saying loudly that I am having myofascial pain syndrome. Okay. So that is a local twitch response. If we get, it is well and good, but if we don't get, it does not say that the patient is not having MPS. Then there will be some amount of motor weakness and restricted range of motion, but no atrophy. Then this is very important. Autonomic features like vasodilatation, vasoconstriction, lacrimation, piloerection, these can also be seen. Because once I had a patient in the institute where I did my fellowship, he was having, neck pain, and he was saying whenever the pain is severe, he was having lacrimation. Okay, the lacrimation and
Sweating is also. Do they tell sweating excessive?
Yeah, sometimes sweating also. My patient was having lacrimation. So what I thought is it is kind of a cervicogenic headache or cluster headache, all those things. He was having headache also, pain in the neck, pain in the head. And I presented to my consultant as this is a case of something like a cluster headache or something like that. But then at that point of time, I didn't know that. But again, this is very important. And vasodilatation, sometimes if that area is red and sweaty, don't think it is CRPS. Myofascial pain can also have autonomic symptoms and signs. Okay, so that is important, you should know that. Then coming to what exactly is a trigger point. So this is a definition of trigger point: a hyper irritable spot in a skeletal muscle that is associated with a hypersensitive palpable nodule in a taut band. You look here, this is a normal muscle fibers, and this is the taut band. So first you palpate for the taut band. So within this taut band, there will be a nodule. Okay, there will be something like a nodularity will be there. And within that nodule, the most exquisite point of tenderness, that is what is actually defined as trigger point. Or in simple terms, you can just take that nodule as a trigger point. Okay. And how do you palpate? It is in this direction, perpendicular to the muscle fibers. Okay. If you palpate like this, in this direction, you may not get the trigger point. You have to palpate actually, ideally in perpendicular to the muscle fibers to see this, to get the palpatory feeling of this trigger point. Now, anybody knows what is this active and latent trigger points? Active and latent? Okay.
In active trigger points, will be pain perceived by the patient as well, and while palpating also we can elicit the pain. Whereas in latent TRPs, there will not be pain perceived by the patient, but when we palpate them, the pain will be perceived by the patient.
Yes, very good. That is correct. Active means spontaneous pain will be there. The patient is already having pain, and when you palpate also, there will be pain. And another one more important point is there. In active trigger point, there will be referred pain. Whereas in latent trigger point, no spontaneous pain, no referred pain. Only when you palpate, the patient will say that I'm having pain. Okay. So that is one. Another thing is primary versus satellite trigger points. So do you know what is this primary and satellite? Primary means this is the area where it all started. Okay. The primary pathology. Satellite trigger points means as the central sensitization and peripheral sensitization happens, the patient will have trigger points in other muscles or other areas also. So if you go and trigger the satellite trigger points, the patient's pain will remain like that. Okay, you have to address the primary trigger point. So how will you know that? There are two things that I commonly use. One is, as I said, reproduction of patient's pain. Which one is producing the reproduction of patient's original pain? Second again is referred pain. Only the primary trigger point will cause referral of pain. The other one will be more like a local pain. So sometimes it's very difficult. Patient will have so many trigger points in so many muscles. To identify which one is the primary is a little bit difficult. But the important point is, unless you deal with this, there will not be any improvement for the patient, especially if you're thinking of needling. Otherwise, it's okay. So this is how you palpate for the palpatory techniques. This is perpendicular, that is, you have to flat palpation perpendicular to the direction of muscle fibers. You can do pincer palpation also. Usually, trapezius and all, when you do the pincer palpation, you will get that nodule feeling. Sometimes you may miss in this palpation, but you will get in this particular palpatory method. And referred pain. So you should actually go to, you can take any textbooks or search in the literature, the common referral patterns of various muscles. So trapezius, if the anterior trapezius is involved, the referral pattern will be like this. So this was my patient who came in during my fellowship. I told you just before, he was having this trigger point in his anterior trapezius, and he was telling of pain, neck pain, headache, and lacrimation. So I thought this is cluster headache. So this was trapezius, and he got excellent relief with trigger point injection. And again, this is trapezius, upper trapezius, posterior and upper. So this causes a trigger like a referral pattern like this. And lower trapezius, it causes a diffuse referral pattern like this. So you should know the common referral patterns to diagnose which muscle is involved. Right. Now, pathophysiology, I'm not going into detail, but you should know that there is some supply-demand imbalance taking place in the muscle. The demand is more, but supply is less, because of which the muscle goes into little bit of ischemia and hypoxia. So this causes a release of various substances like this, and that activates our peripheral nociceptors, which causes local pain, then peripheral sensitization, central sensitization, and when central sensitization happens, then referred pain also comes. Okay, that is a pathophysiology. Now, as I said, how will you make the diagnosis? It is a clinical diagnosis. So this I have already told you, two important things. Okay, compress the trigger point manually and ask two things. One, if the spot is tender or painful, and if so, whether that pain resembles the patient's usual pain. Okay, just on compressing the trigger point, you should ask this question. Whereas you should wait for 5 to 10 seconds, then only you will get the referred pain. So you just press and take the hand away, you will not get this referred pain. You have to wait for 5 to 10 seconds, and you have to see whether there is any sensation away from the area where you are pressing. That is a referred pain. And as I think Dr. Vineetha asked me in the beginning, did I see anything in the ultrasound? For that, you need high resolution ultrasound, and a newer technology is coming, that is sonoelastography, vibration sonoelastography, to know, to identify the TRPs. As of now, our myofascial pain is completely a clinical diagnosis. Now, what are the differential diagnosis? The commonest differential diagnosis is fibromyalgia. Sometimes the patient will have myofascial pain in 2-3 muscles. So whether it is fibromyalgia or myofascial pain. So after the session on fibromyalgia, we will come to know how to differentiate between these two. Then there are several rheumatological conditions like polymyalgia rheumatica and several rheumatological. Because polymyalgia rheumatica, there will not be joint pain. The pain will be proximal, hip, shoulder, so you'll think it is myofascial pain. Then various myopathies, radiculopathy, degenerative arthritis with referred pain, then referred pain from viscera, then somatoform pain disorders, all that we can confuse with myofascial pain. And coming to the management, so how do you manage the myofascial pain? The first is, most often there will be some perpetuating factors. So can somebody tell me what are the perpetuating factors for developing this myofascial pain? Various perpetuating, for example, first we will go for ergonomic factors. So what are the ergonomic factors that can predispose to myofascial pain?
Position, having a wrong positioning.
Is the posture in which we are sitting, working. Okay. And what are the structural factors that can lead to myofascial pain? Structural causes. For example, you take lumbar spine. What are the structural causes?
Means the normal curvature is lost because of
yeah, scoliosis. You can say like scoliosis, kyphosis. All these can predispose to myofascial pain. Then, as I told you, any suppose a facet arthropathy or some kind of a structural derangement in the spine. Then leg length discrepancies. That can predispose to this pain in the legs, back. Okay, so this will tell you the ergonomic factors. So ergonomic factors. Then structural factors like scoliosis, leg length discrepancy, facetosacroiliac joint dysfunctions, arthritis, all this. Then medical factors. Medical factors means it can be hormonal, like hypothyroidism patients, they are predisposed to having myofascial pain, fibromyalgia. So hypothyroidism, testosterone or estrogen deficiency, then nutritional vitamin D deficiency, they can have this vague myalgias and myofascial pains, iron deficiency, anemia. Then some infectious diseases like Lyme disease that also can predispose the patient for chronic myofascial pain. So, and so what was the second management? So after, first of all, you have to correct the predisposing or perpetuating factors. Then what do? You start the patient on a structured physiotherapy or exercise program. So you should first ask them to do the stretching exercises, stretch the muscle properly, followed by strengthening. Then we have various non-invasive and invasive therapies for trigger point inactivation, that I will come to that. And medical management, we can give short course analgesics. Muscle relaxants, is there any role for muscle relaxants? It is more useful in the acute phase. Chronic phase, it is not. The evidence is less for muscle relaxants, because many textbooks and many articles say that muscle relaxants are the first line management for chronic myofascial pain. But if you look little further, it is only useful in the acute phase, not in the chronic phase. And then if sensitization has already set in, we can give some agents for desensitization like gabapentinoids, TCAs, SNRIs, etc. So the trigger point inactivation. So there is manual inactivation just by compressing the trigger point or massaging. That is manual inactivation. Our physiotherapist friends, they do that. Then again, there is electrical stimulation, laser, ultrasound, and then as interventional pain physician, what I do is this invasive therapies like trigger point injections and dry needling. So with trigger point injection, there is always a doubt like what to inject and how much concentration to inject. So there are many pain physicians who inject 2% lignocaine, 1% lignocaine, but that is not needed. It can actually harm the muscle, because if you look at the literature, higher concentration of lignocaine can have what? Myotoxic effects. Okay, so you need to use just 0.25 to 0.5%. What I do is take 3 ml 2% lignocaine and dilute it to 10 ml. That is roughly around 0.5% lignocaine. Then steroids. There is no evidence. These days I don't use steroids at all, except in some muscles like piriformis, quadratus lumborum, sometimes I use in deep muscles, but otherwise no. Then botulinum toxin. Botulinum toxin has got good evidence in certain conditions. One is piriformis, the other one is temporomandibular joint, TMD dysfunction due to masticatory muscles, myofascial pain. So in certain situations, botulinum toxin has got good evidence. That is like what to inject, where to inject, you should know. And how do you inject? So this, what is the technique? What is the problem with this? Is trapezius. What is the problem with injecting like this? I told in the last class, what is the danger if you inject like perpendicularly like this? This is correct actually, you can do, but what is the danger?
Pneumothorax.
Yeah, pneumothorax. In thin patients, you are going perpendicularly. Believe me, pleura is 3 centimeters below the skin. Okay, because I do under ultrasound, I check the depth constantly. Pleura can be as in shallow. It can in thin patients like around 3 to 4 centimeters down. So if you go like this, there is a chance of puncturing the pleura. So this is a better technique. For trapezius, I use this one because here I know that this is the my safe zone. I have taken the muscle between the 2 fingers. Okay, so this much is a muscle bulk. So this is a safe zone. And actually, they have injected here. I go from here. I take little bit above my thumb here and then fan in all directions and do the trigger point injections. And whichever method you do, you have to, especially if you're doing like this or this, you have to fix. I think somebody is unmuted.
Is
So
it
much of
along
disturbance.
the muscle, this like you told last time, along the muscle fiber direction we'll have to inject?
Yes,
right?
ideally it has to be in the along the muscle fiber direction. But this is also described in literature, but I generally do like this. Okay. So muscle fiber direction problem is most of the muscles are oblique. So it is ideally difficult to do it along the muscle in all cases. Some muscles will be like this. No, it is oblique. So along means you have to go like this. So it is difficult. So both techniques I use, perpendicular or along, but you have to, whichever technique you have to do in the fan shape, and you should fix the nodule like this. See, if you do press or use only one finger, the muscle will go to the other direction. The nodule will go to the other direction. So you have to fixate this taut band within the 2 fingers and then go for the injection. Okay. So any doubt in this myofascial pain, then we'll go to fibromyalgia.
Ma'am, I have one question. Have you seen ever after giving trigger point injections, after some time patient had an episode of increased pain rather than improving the pain?
Yes, definitely. Because that is after once the if you're doing dry needling, the incidence is more. If you're injecting a little bit of local anesthetic and doing that, patients will tolerate more. But still, once the effect of local anesthetic wears off, for 2 days, there will be some amount of soreness in the muscles. So we'll advise the patient to do the cold application, ice bath or some cold pack application. So that will take care of the that soreness. Or not all patients will have that kind of a soreness. Some patients have immediate, relief that will be sustained. Some patients, they will have the soreness. And another complication with trapezius is commonly seen with trapezius. Anybody knows that after injection?
That the shoulder will be drooping.
No. Dizziness. In Parliamentary also, when I actually do this procedure with the patient in sitting position, Rajagopal sir tells me, how dare you do in this sitting position? Make the, when I sitting position in the chair, I meant. Sir always tells, make the patient sit in the bed and then do, so that if the dizziness happens, you can change the position to the lying. So this is very common. Dizziness is very common with trapezius. And for that matter, I never do bilateral trapezius simultaneously. With bilateral, the dizziness is even more. There will be a feeling of
the proximity to the stellate ganglion.
Another reason is, the support to the cervical spine.
Okay.
There will be a feeling of instability. When the muscles, immediately when both sides the muscle relaxes, there will be a feeling of instability.
Is it also because of the semicircular canal's alignment after the muscle gets relaxed?
Yes. That is there. And as you said, the proximity to the neurovascular structures, all these can contribute. But this is very common with trapezius.
I have one question.
Yeah.
With this cervical spondylosis, many old patients come with cervical spondylosis and muscle spasms around the neck. And trapezius they have. Sometimes we can't feel any trigger points. Like maybe I'm not used to still feeling trigger points, or Maybe my experience is less, but still, can we do this?
Yeah, if you are not getting any trigger point, but that muscle is painful, that's what you're telling, right?
Yes, yes.
Okay, see, if it is more like a localized, then you can do. But suppose if you are palpating any area in that bilaterally and upper trapezius, middle trapezius, lower trapezius, supraspinatus region, infraspinatus, in all these areas, if you are getting tenderness, then the patient is more likely to have a widespread pain than a myofascial pain. Okay, so you can, whatever I have told in the clinical features, like you can not just the local pain, any referred pain, you may not get the nodule in all the patients, even if you are experienced. The node, what I believe more commonly or what I practice is referred pain. You know, feel for the muscle, any nodularity, then it is just a local pain or referred pain, reproduction of patient's pain. So all this, and then depending on the, you know, which muscle is affected. Last time I told you in the neck pain session, trapezius, if this side trapezius, what movement causes worsening of the pain? Suppose right side trapezius is affected. Which movement causes worsening of neck pain?
Left side movement.
Left, very good, very good. So similarly, quadratus lumborum, lateral bending. The patient is having right side quadratus lumborum myofascial pain, then bending towards the same side. That for QL, it is a bending towards the same side. So that will cause the pain. So similarly, I believe on such things also, and from the history and examination, what worsens the pain. So this arrive at the diagnosis of trigger point, because if it is a deep muscle, otherwise also you are not going to palpate the trigger point. We will not get, we will not be able to palpate a trigger point in the piriformis, quadratus lumborum, iliopsoas. All these are deep muscles. So you have to use the other salient features of diagnosis.
Should we use this only for chronic patients or like less than 3 weeks pain if somebody?
That is a very important question. I don't do, but there are people, physicians who are doing that. There is no harm in doing that, but by definition, but not by definition, but usually myofascial pain syndrome is a chronic condition. Okay. So in that situation, in chronic condition only, whatever I told in that pathophysiology, the supply demand imbalance, all these things happen in that chronic condition. So there is a reason why you are doing this trigger point needling. But suppose if it is acute, it is more of a muscle spasm. Why are you doing trigger point? Give a muscle relaxant. The patient will get a better benefit. Okay, analgesics, muscle relaxants, that will give the patient a more benefit in the acute phase. There's no harm in doing, but
what muscle relaxant do you prefer? Chlorzoxazine or
tizanidine, chlordiazepam epoxide, then epidisone, but mostly tizanidine.
Okay.
And another thing what I was going to tell was, recently the neurologist was telling me that is, for example, you asked me in the acute condition, a patient was having, you know, acute radiculopathy, cervical radiculopathy. There, this muscle spasm is a protective feature. In an acute radiculopathy, that acquired, you know what, straightening of the cervical spine, and that spasm actually helps to, that is protective. Just like we say acute pain is protective and chronic pain is destructive, this acute muscle spasm has got a protective nature. So if you are triggering and you're relaxing the muscle, the patient may develop more symptomatic. The patient becomes more symptomatic with respect to the radiculopathy. So that is why in acute cases, this triggering is not indicated that much. It will not be that useful also. So I think we'll go to fibromyalgia. Any other questions with myofascial pain?
In how many days patient will get relief?
Pardon?
In how many days patient used to get relief?
Usually like around 70% of patients will get immediate relief, and some 20-30% patients, there will be some muscle soreness for 2 days, which will gradually wean off. And another thing is, for some patients, especially if they are having this myofascial pain for like years, 3 years, 5 years, then you have to do repeatedly in every 2 to 3 weeks, one session for 2 to 3 sittings. But if it is more recent onset, like 3 months, 6 months, sometimes one sitting will suffice. Okay. So I think,
So sorry, ma'am. Have you given these injections on the tender points?
That's what I think Dr. Vineetha was asking me. You can give if you feel it is myofascial pain syndrome, because you are telling that you are not getting that features of trigger point. It is just tenderness, right? If it is just tenderness, there is no fibromyalgia. I'm coming to that. There is the evidence says there is no use to it. I'll come to that in fibromyalgia. Okay. Yeah. So we'll go to fibromyalgia, a difficult topic, a difficult patient to treat, and a difficult topic to study also. It's a very nightmare for the patient as well as the pain physician, and so many patients will be referred to you. Usually it is very difficult to get reference from other physicians, for example, for back pain or knee pain. But these patients, they will very happily refer to you for management. So fibromyalgia is the that prototypical centralized pain condition, which is characterized by widespread body pain, comorbid symptoms such as fatigue, sleep, and memory problems. And the ACR 2016 criteria is the latest criteria for diagnosing this fibromyalgia. So many of you might be already using this. This part is the widespread pain index, WPI index. So you have to keep a printout of this in your OPD, okay? And ask the patient to tick wherever he or she is having pain. So widespread pain index, WPI, total score is 19. So you have to see how many areas the patient is having pain. Then second part is the symptom severity scoring. Symptom severity again has two parts. In the first part, it is fatigue, trouble thinking, waking up tired. So they have to score it 0, 1, 2, 3. Second part is, do they have abdominal cramps, depression, headache? No and yes. Then, are the symptoms present for at least 3 months? And is there any other condition that can explain, any other cause that can explain? So if this much is met, you can see the scoring here. WPI more than 7, symptom severity more than 5. If WPI is 3 to 6, symptom severity more than 9, minimum 3 months duration, no other cause, then you can diagnose it as fibromyalgia. Okay. Then what are the risk factors? Female gender, then genetic predisposition. This is one difference. Myofascial pain do not run in families usually, but fibromyalgia, it runs in families. Then inflammatory arthropathies. Almost 15% of our rheumatology population, they will have fibromyalgia coexisting with the rheumatoid arthritis. Then physical stress or trauma, psychological distress, febrile illnesses, certain febrile illnesses like Epstein-Barr, then hormonal causes like hypothyroidism. So I told that in inflammatory arthropathies, fibromyalgia can coexist. So can you tell me what is the advantage or what is the benefit in identifying that this patient is having a coexisting fibromyalgia? Because
we can correct the correctables.
Because another thing is, this is known as secondary fibromyalgia, secondary to an autoimmune condition. Here, there is no benefit in increasing the DMRDs. That is, a rheumatology patient is coming to you with widespread body pain. You have to categorize whether the patient is having more rheumatology symptoms like joint stiffness, joint swelling, joint pain, or a widespread pain. If it is a widespread diffuse pain, more like a fibromyalgia, and you increase the disease modifying, drugs like sulfasalazine, hydroxychloroquine, the patient will end up in toxicity. There won't be any benefit. The patient will end up in toxicity. So it is important to recognize this secondary fibromyalgia. Okay. No, can everybody else mute, because there is a disturbance coming, some speaker or something. Okay. When you answer, you can unmute and say, okay. Now, so what is the basic pathophysiology in fibromyalgia? It is a globally altered or globally augmented central processing of pain. You can say it is a pain amplification syndrome. Everywhere it is amplified. Then there are so many other like genetic expressions, altered neurochemical milieu in the brain and like that. Now, it has been found that fibromyalgia patients have higher levels of neurotransmitters that upregulate pain, like glutamate, and lower levels that downregulate pain, that like norepinephrine and GABA. So there is a imbalance in the neurochemical mediators of pain. Then there is a paradoxical increase in endogenous opioids. That is why fibromyalgia does not appear to be responsive to opioids. Opioid receptors are less and endogenous opioid receptors are downregulated, and endogenous opioids are more. Paradoxical increase is seen. That is why it does not appear to respond to opioids. This is very important, because if you don't know this, then you will just go on escalating the opioids. So what all things happen in this fibromyalgia spectrum? One is widespread pain. Second is prolonged morning stiffness, which I already told in the last class. Around 2 to 4 hours of stiffness may be there. Insomnia and fatigue. 80% patients will have insomnia, fatigue. Then cognitive and affective issues like inability to concentrate, anxiety, depression. 60% patients will have urinary complaints like painful bladder, interstitial cystitis. Then 30 to 50% patients will have irritable bowel syndrome, bowel complaints. So it is very important. It is very important that you ask for these symptoms in a patient, because you have a doubt whether it is a widespread myofascial pain, or it is a fibromyalgia, or is it something like a diffuse bony mets. Some patients with cancer, they will have, as I told you in the CA breast patients in the case scenario 2, she is having widespread pain. It may be due to metastasis, like extensive skeletal metastasis. Then also the patient will have pain in the arms, thighs, and legs. So it is important that you ask for these other symptoms that you see in fibromyalgia. That she has headache, abdominal cramps, insomnia, fatigue, cognitive issues, urinary problems, bowel symptoms, diarrhea, alternating diarrhea, constipation. So all this help you to identify whether it is fibromyalgia or something else. And the pain in fibromyalgia, it is usually musculoskeletal. That is, and all you know that diffuse, multifocal, difficult to localize, and there will be paresthesias, numbness, tingling. So you may think that this is some kind of a radiculopathy or something like that, but fibromyalgia patients will say. But an important feature is, radiculopathy patients will say radiculopathy, or say, for example, someone like CRPS or brachial plexus injury or radiculopathy, they will say that one particular dermatome or one particular area they are having numbness. But these patients, the paresthesias will be diffuse. My entire leg I am feeling numbness, tingling. My entire body I am feeling numbness, tingling. So that is one clue that it is fibromyalgia. Then there will be allodynia, hyperalgesia, because this is central sensitization. And along with that, because I told mostly it is musculoskeletal, but sometimes because it is a globally amplified pain syndrome, there will be headaches, sore throats, chest pain, abdominal pain, pelvic pain. So just because the patient is having sore throat or chest pain, don't send a consultation for a cardiologist for a chest pain. All these can happen in fibromyalgia, because it is a pain amplification syndrome. Pain can happen anywhere. So the differential diagnosis. So now can you tell me some points to differentiate? The most important differential diagnosis is myofascial pain. So can you tell me the differentiating features? How will you differentiate between myofascial pain and fibromyalgia? Because I am tired of talking. Now you will talk and then I will continue.
Fibromyalgia widespread location. Myofascial have a localized area,
Yeah.
and fibromyalgia will have a tender point. Myofascial will have a trigger point.
Okay. Yes, yes.
In fibromyalgia, early morning stiffness.
Female predominance, whereas myofascial don't have like that.
Okay, predisposing factors. Okay, female preponderance, genetic predisposition, all these are seen in fibromyalgia. Also, autoimmune conditions. The conditions that predispose to fibromyalgia, rheumatology, hypothyroidism. All this will be hypothyroidism. Actually, both you can get both myofascial and fibromyalgia. But rheumatology population. Okay, so all these are there, predisposing factors. And then she told that one is localized, the other one is diffuse. Okay, in one you have trigger points. That means you will get referred pain. The other one is Tender point. You will not get any twitch response or referred pain. Okay. Then anything else? Another important feature which I told now.
Early morning
Morning stiffness.
Okay, morning stiffness. There will be marked morning stiffness. Again, another important point I told in the just slide. That is
Sleep
just the previous slide.
disturbances.
Pardon?
Sleep disturbances.
Sleep disturbance and other symptoms.
Bowel
like-
and bladder.
Yes. Point for Sunil sir. Bowel and bladder and all this, other disturbances, headaches, all these systemic symptoms, you can say. These are common in fibromyalgia, not in myofascial pain. So systemic symptoms, seldom reported. Trigger points, we already discussed. Tender points, we already discussed. Response to trigger point injection. This is the last one. Somebody was asking me, in fibromyalgia, the response is often poor. Okay. Whereas in this trigger point, it is immediate and it is very good response. And something else is there, which this I don't understand actually. Even though this is in my slide, I took it from one of the textbooks. The fibromyalgia, the range of motion is increased. I don't know why, because practically in both situations, the range of motion is restricted. But there is one difference. The other one, it is like in a myofascial pain, there will be upward straightening of cervical spine. Even if until that is corrected, the patient will not be able to improve the range of motion. In fibromyalgia, it will be a waxing waning time. Sometimes the patient will move the area correctly. Sometimes they will restrict due to pain. So the range of motion for practically it is restricted in both.
Ehlers-Danlos syndrome, there are cases of fibromyalgia.
BJHS, benign, joint hypermobility, Ehlers-Danlos. In that case, Ehlers-Danlos, always the range of motion can be increased. But generally in fibromyalgia, what do we see? The patients, their activity is very less. They don't move any joints for that purpose.
Yes.
Okay. And these are other conditions that, simulate fibromyalgia, hypothyroidism. I already told polymyalgia rheumatica, autoimmune disorders, then some viral infections, drug-induced. And this is a basic testing you should do. CBC and serum creatinine. Serum creatinine, especially because, is Dr. Vineetha, you have a question?
Can you tell about the seronegative arthritis somewhere? Because
seronegative arthritis is because ESR, CRP, everything will be negative. And the RA factor will also be negative, but the patient will be having joint pain, stiffness, and how do they diagnose it usually is that rheumatologists, they have a subset of investigations. And practically for us, one important factor that will help to differentiate is swelling.
Early morning stiffness.
Swelling. Yeah, early morning stiffness, swelling. Because the joints will be swollen. Small joints, yeah. The fibromyalgia, there will be a subjective feeling. The patient will say that my neck is swollen like that, but there will not be joint swelling as such. Okay. But in rheumatoid arthritis, seronegative arthritis, there will be usually joint swelling also. And then rheumatologists, they have some other investigations also that they do to identify the seronegative rheumatoid arthritis. So basically, why I do serum creatinine is because these patients are on NSAIDs for a long time. So it is important that you check the serum creatinine also in the first visit. These two textbooks say is a must. ESR to differentiate from polymyalgia rheumatica and other rheumatological conditions, and TSH because hypothyroidism, both myofascial pain and fibromyalgia are common. Okay. Then other tests like ANA, rheumatoid factor, only if you have that much of suspicion whether it is a rheumatological condition. So ESR is basically to more differentiate from polymyalgia because polymyalgia, small joint, swelling will not be there. Small joint swelling pain. So it actually looks very much like fibromyalgia. So you can differentiate with the help of ESR. ESR will be in 60s, 80s or 100s in polymyalgia rheumatica. Okay. Now coming to the management. So something somewhat similar to myofascial pain, but here patient education is very important. So what do you educate the patient? What will you tell the patient? Or why patient education is important?
Because the pain completely cannot go away.
Very good. There should be some kind of an acceptance from the patient's side. And believe me, if that acceptance is not there, somehow nothing is going to work actually for the patient. So you have to educate the patient. It is not like you have to tell them whatever I do, you are not going to get cured. But you should tell that this is a complex condition. It is a challenging to treat. You need to give us some time. All the medications that we start will take some time to work, and it should be multimodal. All this exercises, psychological therapies, everything should work together. So that kind of a patient education, modification of activities, all this is important in fibromyalgia. And exercises. This is very important because many of my fibromyalgia patients, I tell them that you go to the physiotherapy in my hospital. They won't go sometimes due to financial issues or something else. They go to the physiotherapy centers near their houses. What happens is immediately the physiotherapist will start pressing everywhere. We'll tell them that you are having trigger points in all these muscles. I will massage and correct all these trigger points. The patient's pain will increase. And also second, they will immediately start the stretching exercises. It is not like that. In fibromyalgia, the first target is make the patient more active. That they are now they are functionally, they are not doing anything at all. So ask them to actually move around in the house and try to make the patient more active. You can try a short course of analgesics also. Then mild exercises like walking in front of the house for 10 minutes or something like that. Then you have to upgrade to other aerobic exercises like jogging, cycling, running, or just as much as how much the patient tolerates. Then stretching. Then only comes the stretching. Aerobic exercises are more important in fibromyalgia. But in myofascial pain, stretching, you stretch that particular muscle and strengthen. That is more important. Whereas in fibromyalgia, aerobic exercises are more important. Then stretching and strengthening. Then physiotherapy modalities like ultrasound, interferential therapy, TENS, all this will give short-term benefits. And one particular technique with now growing evidences, transcranial magnetic stimulation. It is a non-invasive stimulation of the CNS. And now the recent literature says there is some evidence, supporting the benefits of this transcranial TMS, magnetic stimulation. I don't have it. I don't think any hospital in Kerala has TMS at this point of time. So I'm not able to, I don't have a personal opinion, but books and literature, of course, says TMS has got a positive evidence.
Vineetha,
Yes.
In the patient education, I think one of the most important things, in addition to what you have told,
Yes.
most of the patients, there is nothing visible for others to see that the cause of pain. And mostly this caregivers will be taking the patient from one doctor to another, and they have lots of problems. And most of them might have told them also, no, we couldn't see anything that is giving rise to pain. So when they reach to us, we should actually acknowledge that, okay,
Yes.
there is something called as fibromyalgia that can produce, we understand that. So I think that's important. Otherwise, not only in case of fibromyalgia, but in case of any types of chronic pain, that acknowledgement is very important.
Yes, yes.
And
this is not a psychiatric condition.
Yeah, and if they go to another doctor and telling that this doctor has made a diagnosis of fibromyalgia, mostly the other doctor would tell there is nothing called as fibromyalgia. That's also another problem.
Correct, correct. That is correct. That comes in patient education, that as I told, acceptance, and you have to acknowledge that the patient, that you have to tell the patient that, see, fibromyalgia and somatoform pain disorder sometimes looks, I think that was there in the differential diagnosis also. Psychiatric conditions, somatoform pain disorders, they look very much alike. And so if you are convinced that your patient is having fibromyalgia, you should tell them that there is a condition like this. And I usually tell my patients this pain amplification, that in layman's language, that all the neurons are, pain processing neurons are hypersensitive. And that is why it is happening. This particular problem is happening. And there are, of course, many treatment modalities that we can offer you, but there is nothing magical that we can do to make you pain-free in 1 day or 1 week. It will take some time, and it may not be completely curable, but we can try together to give a more meaningful, make the patient more functional, improve the quality of life. So all these things should be explained well to the patient. And so, like sir correctly pointed it out. Then CBT. So even though the fibromyalgia is, psychological distress is something that predisposes the patient to cause fibromyalgia. And the reverse also is true. Fibromyalgia patients will have some amount of anxiety, depression, but it is different from somatoform pain disorders. And these patients should be given cognitive behavioral therapy. This mindfulness, relaxation, and all these techniques should be taught to them. And if you send them after, say, 3 months of therapy, they will think in this way. Now this doctor has tried everything else. Now he is telling me to go to the psychiatrist or psychologist. Okay, believe me, that patient will not go. So you have to tell them in the first sitting itself, this is a multi-pronged approach. On one side, there is patient education, then physiotherapy, that physical modalities, then this cognitive behavioral therapy, then we have our pharmacological therapy intervention. So you have to tell like that in your first visit itself, or maybe the second visit. Otherwise, the patient is not going to go. Okay. And somebody was asking me, I think Dr. Vineetha was asking me this last time, what is the evidence for this complementary and alternative medicine CAM therapies in chronic pain, like acupuncture, yoga, tai chi? So that is why I took this sentence from this guideline, so this article. So they say that as with other diseases, like other chronic pain conditions, there are few controlled trials available to advocate their specific use in fibromyalgia, but there is general agreement that the evidence base for using these therapies across pain conditions is increasing dramatically. So over the years, these therapies are being increasingly used for treating chronic pain conditions. But if you look at the evidence, we don't have much controlled trials to say that this is effective in this, except for what I told you in last class also, this American College of Rheumatology, ACR, recent guidelines on arthritis, osteoarthritis, they have recommended with a very good evidence that Tai Chi is good for osteoarthritis. But other than that, I don't see, or I haven't seen any guidelines recommending anything for any condition. Because for a guideline to recommend, there should be a good quality RCTs. That is not there. But these therapies can be, the patient can try for, at least for short-term benefits will be there. So then coming to pharmacological therapies. So you can tell me the three FDA approved drugs for fibromyalgia. Anybody? FDA approval does not mean that. Yes, duloxetine. Second, pregabalin. Yeah, pregabalin, duloxetine, one more.
I'm not able to pronounce it.
Milnacipran. Okay. So FDA approved does not mean that these have the highest evidence, but whether FDA approval does not have much importance in India, I think. But anyways, they say that these three has the highest evidence in, but if you look at different articles, the evidence is conflicting, but still, these are three FDA approved drugs: pregabalin, duloxetine, milnacipran. It's available in India, I think, but not in our part of India anyways. I am not getting this drug. And there is equally strong evidence for tricyclic antidepressants, amitriptyline. Okay, so how do you select a drug for this? This rule is same for neuropathic pain also in the next topic that we are going to cover. So how do you select from this pregabalin, duloxetine, and milnacipran? For example, a patient is having pain and sleep disturbances. So what will you start? From these four drugs, a young patient like 30-year-old young patient, a 30-year-old lady with, fibromyalgia and sleep disturbance, what will you start? Amitriptyline. Anything else? Duloxetine. Anything else? Two more drugs. For the time being, we'll forget milnacipran. So nobody for pregabalin? Is pregabalin so notorious here? Nobody for pregabalin? Okay, I'm laughing because this is one of the first drugs that I start for fibromyalgia. Okay. Okay, my question is 30-year-old fibromyalgia lady with insomnia. Amitriptyline anyways is a correct answer. Okay. So my second question is I'll tell why amitriptyline is correct. Second question is not 70, maybe like 65, 70-year-old fibromyalgia patient with same insomnia. What will you start? Mood is okay, but insomnia is there. Again, is your first choice amitriptyline?
No, pregabalin.
Yeah, pregabalin, gabapentinoids. Okay. Now the second question is, the patient is having pain and depression. Then the first choice is duloxetine. Now the patient is having pain, insomnia, and depression. Now how will you combine?
Duloxetine plus pregabalin.
Duloxetine plus?
Pregabalin.
Yeah, duloxetine plus pregabalin or duloxetine plus pregabalin or amitriptyline. Again, pregabalin and amitriptyline you can decide whether patient is young, because all patients will not tolerate amitriptyline. Elderly patients, they will not tolerate amitriptyline. So whatever I have told, I have written here. You can go to this later. Okay, that is how you decide. The same holds true for neuropathic pain also, almost like this. Now, other drugs, you can try, SNRIs. What is the problem with venlafaxine? If duloxetine is FDA approved and famous, why venlafaxine is not that beneficial for fibromyalgia or for any neuropathic pain or these conditions? We always talk about duloxetine. Why not venlafaxine? What is the problem? So basically, duloxetine has got almost same noradrenaline and serotonin reuptake inhibition. Okay, whereas venlafaxine, it has more of serotonin reuptake inhibition, less of norepinephrine. For pain, what is important? Serotonin or norepinephrine? You remember the first class on sensitization? Yeah, it is noradrenaline is important. Norepinephrine is important. So venlafaxine only at high doses will cause this reuptake inhibition of noradrenaline. It is more like serotonergic drug. So that is why venlafaxine and these SSRIs are less beneficial in fibromyalgia and neuropathic pain when compared to TCAs and duloxetine. Gabapentin, already told pregabalin, gabapentin is also effective, just that FDA has ignored gabapentin, but it is also effective. Then this is something which is gaining importance, gamma hydroxybutyrate, or earlier known as sodium oxybate. This has been proven, beneficial for this sleep disturbance in fibromyalgia. So I searched, it is available in India, not in my hospital, but it is available in India. Okay. Then muscle relaxants may be tried in the initial phase like tisanidine. There are some literature supporting tisanidine. Then NMDA antagonist and ketamine and lignocaine, I'll come to that. Now, there are two drugs, not two drugs. Can you say the drugs without that we commonly use for pain, but no proven evidence in fibromyalgia? One is NSAIDs, the other is opioids. Okay. And in fact, this article says that opioids may worsen hyperalgesia because especially morphine, okay, because some people have found out that the basic biochemistry in that fibromyalgia, that biochemical milieu, you can tell, that is very similar to opioid-induced hyperalgesia. So if you give further opioids, it may actually worsen the hyperalgesic part. And I have given the reference here, you can go back and read. And if needed, it is better to use the opioids with other mechanisms of action rather than just new opioid agonistic activity like buprenorphine, methadone, tramadol, and tapinaroid. It is better not to go with the pure mu agonists like morphine and fentanyl. Okay. Now coming to the systemic infusion therapies, and both these articles are very good. Especially, I will tell every one of you to save this in your desktop. This is consensus guidelines on the use of intravenous ketamine infusions for chronic pain. Very, very, very nice article that you can clear all the doubts on ketamine, including the adverse effects, for which condition it is more effective. This guideline is from the American Academy of Pain Medicine and American Society of Anesthesiologists. Okay. And so this is 2018, so a recent one also, relatively recent. So ketamine infusion. So can you tell me what is the evidence for ketamine infusion in fibromyalgia? Is it good, bad, compared to other situations where you use ketamine infusions, like CRPS, neuropathic pain?
In what sense you're asking? I didn't understand.
So this ketamine infusion, like many of you might be already practicing, right, for fibromyalgia, ketamine, lignocaine infusions. What do you think is the evidence of how much beneficial do you think is ketamine and lignocaine for fibromyalgia? That's what I'm asking.
No, but like central sensitization, I thought it would
Yeah, it
reduce.
works by NMDA antagonistic activity. So definitely there is a role in desensitization. But if you look at the evidence, this article, this Cohen SP, this article, they say that it is effective in neuropathic pain and CRPS, but not in fibromyalgia. Okay, and this is the dose that they commonly we see. It ranges from 0.3 mg per kg to 0.5 mg per kg. Some studies they give it over 10 minutes, and some studies they give it over 3 hours. There are more. Even I have seen a study we using 3 milligram per kg over 5 hours. But most commonly used dosing regimen is this 0.3 to 0.5 mg per kg over time ranges from 10 minutes to 3 hours. And lignocaine infusions, so the commonly used is 3 to 5 mg per kg. Some studies they give it over 1 hour, some they give it over up to 4 hours, 5 hours, like that. And it has been found to provide short-term benefit in fibromyalgia. And better analgesic benefits may be obtained. This particular study says that with higher doses like 7.5 mg kg without significant adverse effects. So in neuropathic pain, maybe you should first go for ketamine infusion, and because for neuropathic pain and CRPS, ketamine infusion has got a higher evidence that in fibromyalgia. Whereas in fibromyalgia, you may first try lignocaine infusion and then go for ketamine. There is no hard fast rule, but there is some evidence to say that ketamine is not that efficient in fibromyalgia when compared to neuropathic pain or CRPS, whereas lignocaine has got at least short-term benefits in fibromyalgia. Okay. So this is another important article. You can go back and yeah, some people have raised their hands.
Do we need to use any pre-medication for ketamine infusion?
Yeah, yes.
For 3 hours or 10 minutes?
Benzodiazepine and antiemetic for ketamine. And what all you have to check during ketamine is, of course, you have to monitor the patient heart rate, BP, because ketamine can cause tachycardia, hypertension. Then some other things which you may be less aware, especially if you're giving for 5 days. There are several infusion protocols. Most of the infusion protocol that I have seen is they give it over 3 hours in 1 day, 2 hours, 3 hours. Then ask the patient to come like every 2 weeks or 3 weeks and just repeat the same thing for a few months. But sometimes we admit the patient and there is IP protocol, like we give a few hours every day and we continue that for 5 days, 3 to 5 days. In that situation, you have to check, the LFT also. Ketamine can produce, LFT derangement. Ketamine can produce interstitial cystitis. Ketamine can produce delusions, hallucinations, all the psychomimetic disturbances. So all this you have to be careful while you are giving ketamine. Similarly with lignocaine, arrhythmias and local anesthetic systemic toxicity, all this can occur. So this particular guideline, this update on treatment guideline in fibromyalgia syndrome with focus, everybody should read this because they are discussing various other guidelines in this particular article, like ULAR guidelines, Canadian CPS guidelines, AWMF, all these guidelines, what they say, that has been discussed in this particular one article. So you will get to know how fibromyalgia is treated in everywhere across the globe. Okay, because these are different from different countries, these guidelines. Okay. So that is about fibromyalgia. Any doubts we can clear now, just 3 minutes, and then we will go to our neuropathic pain and CRPS. That's the last session.
As the drugs which you specified for that regarding depression, along with pregabalin plus duloxetine. Is there any role like insomnia, depression, and mirtazapine role in this, in such
Yes, yes.
scenario with
Mirtazapine
depression?
Yes, yes. I just told this with the help of the 3 drugs which is FDA approved and the strongest evidence. But mirtazapine can be given for, especially in mood and anxiety, correcting the anxiety depression part, but not much evidence in pain. For pain, you have to give something else, bring up pregabalin, and you can combine with mirtazapine.
Thank you.
Ma'am, for acute phase, when the patient is in acute pain flare-up, what do you usually advise? Do you advise any NSAID with muscle relaxant during that phase?
Yeah, actually, NSAIDs, as I told us, there is no proven evidence, and many studies have found it is similar to placebo. Whereas certain studies, they say that even though it is a central amplification, the pain comes from the periphery. So if you block what is happening in the periphery, then there will be some benefit in fibromyalgia. So you can give a small trial, maybe 5 days or something. But what I usually do is, I give, for example, I start directly with pregabalin and paracetamol, because NSAIDs already the patients might have used for quite a long time. These patients will not come to us for the first time. So they might have already used this. So I give either paracetamol or tramadol rather than NSAIDs. And then muscle relaxant, of course, in the initial phase, you can give a trial of tisanidine. It helps in sleep also. So that can be given, muscle relaxants and this paracetamol, tramadol, something like Ultracet, and then start on pregabalin or whatever the other agents.
Ma'am, with the muscle relaxants, with the anticonvulsants, the increased probability of drowsiness will not be more side effect profile?
Yes, that is there. In such some patients, what I do is I give for 1 week analgesics and this tisanidine, and then only start them on pregabalin. You can decide. Most of them will complain of insomnia, so it is acceptable. But if you think the patient, that varies from patient, but that problem is there, definitely there. And another problem that we didn't discuss is, you told about combining amitriptyline and duloxetine in the last thing, pregabalin, sorry, pain plus insomnia plus depression.
Depression, yes, ma'am.
There is a one possible complication when you are combining amitriptyline and duloxetine. What is that? What is that? And tramadol also. If these 3 together.
Serotonin syndrome.
Yeah, serotonin syndrome, because all these are causing reuptake inhibition of serotonin and noradrenaline. Not they will have, taken one patient recently. It was under physical medicine and rehabilitation in our hospital. Just with 70 tramadol, 150 per day, amitriptyline 25, and duloxetine, I think 30 milligrams. These are small doses of the drugs, but this patient developed serotonin syndrome. You have to be careful when we are combining all these drugs.
Ma'am, do we have any antidote or something for serotonin if anybody developed such?
No, I don't know. There is no antidote, just symptomatic management, supportive treatment, and
so
stop the drugs.
The drugs, taper it, that
yes.
Okay.
Yes. Stop the offending drugs and then manage the hypertension, tachycardia. That's it. Okay, so all these you have to be careful when you are putting these all the patients on amitriptyline, pregabalin, duloxetine together.
How have you seen the patient compliance towards the medication, especially with the fibromyalgia patients?
Compliance?
Yeah, medication compliance, because I've seen very poor compliance.
Yeah, very poor compliance is possible. That is where the role of this patient education is there. If we educate them in the beginning, we can improve the compliance. But definitely, because another thing is why there is poor compliance is, we should tell them that this will take some time. Neuropathic pain also, that is true. Whenever you start the patient on, pregabalin, amitriptyline, these drugs are not going to work overnight. So that has to be specifically told to the patient that this will take some time. So that good proper patient education, then telling them that this will take time, and proper telephonic follow-up. You can ask some staff of you to call them and ask them in between 2 weeks, 3 weeks. They may not be able to come every 2 weeks or 3 weeks. So all these will help to improve the compliance, but it is definitely there are chances of poor compliance because they will be fed up going from one hospital to other.
Okay.
So I think, yeah, we'll go to the last session, that is neuropathic pain and CRPS. So neuropathic pain, I think everybody knows the definition of neuropathic pain. It is caused by a pain caused by a lesion or disease of the somatosensory nervous system. And somebody actually drew these two lines, not myself. So Sri Priya, can you erase this?
I'm trying to erase that.
Okay. So then, okay. So this is there. The peripheral and central neuropathy conditions are there. Peripheral as in diabetic neuropathy, post-traumatic neuralgia like brachial plexus. Then central, we have the spinal cord injury, post-stroke, and it is common in neuropathic pain is common in malignancy also due to direct neural compression, or it can be chemo or surgery induced, just like our second patient who post mastectomy neuropathic pain. Okay. And what is a general approach? This is an algorithm. You might know the WHO analgesic ladder for nociceptive pain. Similarly, there is a ladder for neuropathic pain also. So they say that the first line should be gabapentinoids, SNRIs, TCS, and for post-herpetic neuralgia or regional syndromes, topical therapy, lignocaine, capsaicin. So this you have to give a 4 to 6 weeks trial, and you have to tell the patient also it will take time. Then the second line is combination of first line agents plus tramadol. Even though they say tramadol as second line, I usually use it as first line for neuropathic pain. Then third line SSRIs. I told why it is third line, because it has less effect in pain than on depression. So SSRIs, other anticonvulsants like carbamazepine, NMDA antagonists like ketamine, then interventions like sympathetic blocks. All these come under third line. Fourth line, neuromodulation, but we don't do much neuromodulation in India. So in India, the fourth line will be the low dose opioids. So it is very important that you have to give 4 to 6 weeks of trial of opioids only after trying these three lines, these three managements, okay, and tramadol. Then only go for the strong. This is strong opioids, so low dose opioids. Then sixth line is targeted drug delivery or intrathecal pumps. So neuropathic pain, the right drug for the right patient, this I have already discussed. Only this is left. That is, there is something new coming up known as phenotypic management, especially in the diabetic neuropathy. So that is, if the pain is of burning, tingling, pinpricking, they have found duloxetine to be more effective. Whereas it is evoked pain and paroxysmal pain, like shooting pain, then the gabapentinoids are more effective. So you can decide depending upon which is the predominant pain phenotype the patient is having. Everything else I have discussed earlier. Then coming to opioids. So this is opioid effectiveness order. Nociceptive pain more than neuropathic pain, and within neuropathic also peripheral response more than spinal and supraspinal. So if at all you are give tramadol, tapentadol, buprenorphine, methadone, and oxycodone, they have more evidence. Then morphine, there is mixed evidence. One European Journal of Pain, there's an article, they say that there is low to moderate quality evidence that it is beneficial. Whereas a Cochrane review, they found out that even doses up to 180 milligram is only as effective as placebo, or is actually ineffective. Even high doses they have tried up to 180 milligram, it is ineffective. Okay. And there are some guidelines on how you have to use opioids for non-cancer pain. So this is very important because, as I told in the first class, we as pain physicians, we are very confident about using morphine, and we are very confident on going up the analgesic ladder. What if the patient does not respond to step 1? We'll go to step 2. If not step 2, we'll go to step 3. What is the big problem in that? I know to titrate, but you should know which condition responds and which condition will not respond. So here, when you're using for non-cancer chronic pain, there are so many problems like addiction, dependence, hyperalgesia, so many adverse effects. So be using it very carefully. So first of all, you should titrate the non-opioid drugs. Titrate it, optimize it, then only start think about opioids. Don't think that starting opioids will give immediate benefit. Otherwise, also in fibromyalgia, neuropathic pain, the opioids, it is does not have strong evidence. So don't straight away go into opioids. I have seen this happening many times that pregabalin will be still in that small dose, 75 milligram BD or amitriptyline 10 milligram HS. The physician has prescribed morphine. This has happened several times. Okay, that is not correct. You have to optimize the non-opioid therapy first. Then, if there is no active substance or psychiatric disorder, you can give a trial of opioids. If active substance abuse is there, it is not recommended. Opioid trial is not recommended. If active psychiatric disorder is present, you have to stabilize that first. The lowest effective dose for the shortest period is the goal, and it has been found that you have to limit the daily dose to 90 milligram, strong evidence, or 50 milligram, weak evidence. That is, if your patient is not responding to 90 milligram, that is almost like 15, somewhere between 15 to 20 milligram Q4H, don't increase further. Okay, just because in 15 milligram she is having some benefit, don't increase further. It is not recommended to increase more than 90 milligram morphine equivalence. And if controlled on within that 90 milligram equivalence, you should start tapering the dose as early as possible. And if not controlled, go for an opioid rotation or optimize the other drugs rather than just escalating the morphine dose. But this is again a good literature which I have told. You can go back and read. Red line for opioid therapy in non-cancer patients. Then coming to interventions in neuropathic pain, you know, sympathetic blocks, trigeminal neuralgia, there is very good evidence for radiofrequency ablation. Then lumbar radiculopathy is a kind of neuropathic pain. We have good evidence for transforaminal epidural steroids. And this is something I want you all to know, because when it comes to nerve entrapments, carpal tunnel, tarsal tunnel, cubital tunnel, all these tunnel syndromes the surgeons will manage. Okay, but these patients, is highlighted in green, will be sent to you, especially inguinalodynia and orcalgia, because surgeons cannot do anything. Inguinalodynia commonly happens after, multiple inguinal hernial surgeries. Iliohypogastric, ilioinguinal nerve entrapment occurs. Then for melalgia parasitica, it is lateral femoral cutaneous nerve entrapment. And for orcalgia, it is genital branch of genitofemoral nerve entrapment. And for these nerve entrapments, ultrasound-guided nerve hydrodissections using 5% dextrose is more commonly used. Less commonly, steroids have some role when you combine it as a component of multimodal therapy. Okay, you have to do it repeatedly, like 2 to 3 sittings of nerve hydrodissection. Melalgia, it is very effective. Compared to that, less effective for orcalgia. Inguinalodynia is very challenging, even with nerve dissections. I have seen patients suffering like anything. Nothing works for them except tramadol or buprenorphine. I have found to be working effective to some extent. Okay, this is the worst in these 3 things, inguinalodynia. Okay, now coming to a little bit about CRPS, complex region, because it is a if you go by the definition of neuropathic pain, lesion or disease of the nervous system, is CRPS a neuropathic pain or not? Is it always a neuropathic pain if you go by the definition?
Yes. Yes.
No.
No, it's
no, because in CRPS 1 and 2, we'll come to know that only in CRPS 2, there is evidence of a nerve injury, a lesion or disease of the nervous system. If you go strictly according to the definition, CRPS 1 does not come under neuropathic pain. But if you go clinically, if you look at the symptoms, if you do the DN4, then CRPS is predominantly having, be it CRPS 1, then also it is predominantly neuropathic features. So it can be discussed under neuropathic pain. So CRPS describes a variety of painful clinical conditions, regional conditions with a distal predominance. And what is very, very characteristic, it has got a dramatic presentation. The clinical presentation, it exceeds in magnitude and duration of the inciting event. Whatever was the inciting event, the presentation will be out of proportion to that. And there will be significant motor function, and that shows variable progression over time, motor dysfunction. And again, if you look at the predisposition, females are more predisposed, age group 37 to 50 years, upper limb more commonly involved, CRPS1 more common than CRPS2, and 40% cases, at least in 40% cases, there will be history of trauma or surgery. Now, what is the difference between CRPS1 and 2? Just look at this part. In CRPS1, there will be an initiating nauseous event or immobilization, minor things like a sprain, a fracture, minor trauma, or immobilization following CVA or something like that. That will initiate this CRPS type 1, early known as reflex sympathetic dystrophy. And whatever initiated, the presentation is disproportionate to that. Then CRPS type 2 is causalgia. Here, there will be a definite nerve injury. And there will be continuing pain, allodynia, and hyperalgesia, not necessarily limited to the distribution of that injured nerve. We'll come to the diagnosis later. How do you diagnose? Then there is something known as CRPS not otherwise specified. That is, who do not fully meet the diagnostic criteria, but whose signs and symptoms cannot be explained better by another diagnosis. Because I have a 13-year-old child in my care now in my hospital, just 13 years. He, while practicing karate, he was doing that frog jumping during karate, and there was an L4, L5 disc bulge, which is very uncommon in that age group, 13 years. And he was asked to, take bed rest for 6 weeks. So now even in acute disc bulge, we don't actually recommend that kind of a bed rest. But somehow this happened at somewhere else. The patient was on bed rest, immobilization for 6 weeks. At that time, the patient had severe back pain, but now the patient is admitted with back pain, but more than that, leg pain. Leg pain, and there is some amount of edema and discoloration of the foot. So nothing can explain. We have done the neurosurgery department, physical medicine department, and myself, pain medicine. These 3 departments are working together, and tomorrow there is a medical board planned for this patient. Because we have investigated everything, MRI contrast of the lumbar spine, MRI contrast of the pelvis. There is diffuse tenderness, hyperalgesia, allodynia in the low back and the lower limb. But if you go by the diagnostic criteria, there's not much swelling, discoloration, sweating asymmetry. What you commonly see in CRPS will come to that. So if you go by the diagnostic criteria, it is not CRPS, but nothing else can explain his signs and symptoms. And if you go back and look at the literature, there are cases of CRPS reported after an acute disc bulge, acute disc herniation. So now our working diagnosis is that it is a CRPS NOS, not otherwise specified. Okay. Now, what is a pathophysiology? There is sensitization, peripheral, central, sympathetically mediated, a lot of neurogenic inflammation, inflammatory mediators. So all these are, postulated to have a role in CRPS. And the main symptom is pain. The pain like burning, aching, and throbbing pain. And it is asymmetrical, not in the distribution of a nerve, may not have any relationship with the inciting event or the site of the inciting event, and it is always worst distally and aggravated when the limb is in the dependent position. So these are the characteristics of pain in CRPS. So this is a Budapest criteria. You can go back and study this. Like the patient has continuing pain, disproportionate to inciting event, at least one sign in 2 or more of the categories, one symptom in 3 or more of the categories, and no other diagnosis. So in sensory, we have pain, hyperalgesia, allodynia. Vasomotor, we have temperature and skin color changes. Pseudomotor or edema, we have edema and sweating asymmetry. Motor and trophic means decreased range of motion, and trophic changes means nail and hair, skin changes, hair changes, skin changes, nail changes, all these come under trophic changes. Okay. So this is a red, swollen, and shiny looking CRPS limb. This is usually seen in the acute phase. Okay. We come to that next. When you go to the dystrophic or atrophic phase, mostly the muscle, the limb will be more like a, not necessarily, sometimes it will be still red and warm, but mostly it will be cold, cyanotic. Okay, so this, because it will be too much for you if I read all this now. So interested candidates can go back and read. There are 3 phases of CRPS: acute, dystrophic, and atrophic. And why understanding that is important is, See, in the dystrophic phase and atrophic phase, there will be in acute phase, X-ray will be normal. But in the dystrophic and atrophic phase, an X-ray can show osteoporosis. We'll come to that. And the sympathetic blocks, they work better in the acute phase. Steroids, they work better in the acute phase. As you go towards this spectrum, towards the dystrophic and atrophic phase, the effect of these interventions like steroids and pain interventions, all these reduces. All these works better in the acute and the dystrophic phase, not in the atrophic phase. That is why you have to understand which phase your patient is having, whether it is acute, dystrophic, or atrophic. So, CRPS differential diagnosis, other neuropathic conditions, inflammatory conditions, vascular causes, myofascial pain, psychiatric, all these are some differential diagnosis of CRPS. And is there any investigation? No gold standard. It is a clinical diagnosis. You have to diagnose it with the help of the Budapest criteria. But these two you should know. X-ray will show patchy osteoporosis. You can compare these two hands. Here it is normal, but here you can see there is patchy osteoporosis. Okay, periarticular patchy osteoporosis. But this too will be evident in the X-ray only by 3 to 6 months, not in the acute phase. Okay, only by 3 to 6 months this osteoporosis will be evident. That is where this triple phase bone scan becomes important. If you have a patient, if you're working in a tertiary care setup where there is facility for bone scan, and if you are doubtful whether your patient is having CRPS, you can always ask for a triple phase bone scan. This is only one investigation which has got good evidence in diagnosing CRPS, even though it is not gold standard or definitive, but there is good evidence. Okay, so this patient which I have told you, the medical board is planned tomorrow, and we are going to conduct a triple phase bone scan for him after the medical board. And even in the acute phase, this triple phase, that is only 1 to 3 months after the onset of symptoms. Even in the acute phase, this triple phase bone scan will show increased uptake in this periarticular region, that there is this periarticular bone resorption is taking place. So you can diagnose it earlier. Okay. Then the last, coming to the management, just like fibromyalgia, first is patient education. It is complex pain, challenging to treat, but we acknowledge that you are having pain, and we are there to support you and do whatever we can to improve the quality of life. Then we have physical therapy, psychological interventions, and the pharmacological pain medications and interventions. So the physiotherapy, these are the objectives of physiotherapy: to minimize the pain, it will minimize the edema, normalize the sensation, improvement and restoration of functions. And very important is this: initially, when the patients will be in severe pain, they will not allow you to even touch the affected limb. So don't straight away go ahead with physiotherapy of that particular limb. You have to first address the contralateral limb, the normal limb. Okay. And you have to immobilize the affected limb and mobilize the unaffected limb, the normal limb, and then carefully start physical therapy to the contralateral limb. And when you start the physical therapy, first go for passive measures, passive physical therapy, then go for active isometric, and then last you go for active isotonic training. So this is how you have to go ahead with the physiotherapy. Don't straight away go ahead by mobilizing the affected limb. The patient's pain will increase, compliance will decrease. Then psychological intervention. There are a lot of psychological interventions, and you have to start that as I told for fibromyalgia, in the first visit itself, you have to tell them the importance of the psychological interventions, and you have to start this along with other pharmacological and physiotherapy modalities. And this mirror therapy is one intervention, psychological intervention with very good evidence for CRPS. It's simply you have to make a box you can make in your hospital, a triangular or a square-shaped box, and the patient will place the unaffected, this is the unaffected limb, okay, in front of the mirror, and place the affected limb inside the box. So when the patient sees the image in this mirror, and when the patient sees that my limb is moving, the brain gets a inference that this is coming from the affected limb. Even though it is coming from the unaffected limb, our brain will be tricked so that it feels it is coming from the affected limb, and this actually helps in the regulation of the pain pathways or coming from the affected limb. So this is mirror therapy, and similarly graded motor imagery is also similar. That is, you ask the patient to sit like this, take a very relaxing position, and this there will be some person will guide him through the motor imagery, that he will be asked to imagine the affected limb. The patient, the person who is guiding will tell them that just imagine that you are flexing the affected limb. The patient is not actually doing, but imagining that. And I just told in the simple words, it is more than that. So that is what is this motor imagery is. And this is mirror therapy. So motor imagery and mirror therapy has got good evidence in CRPS, along with CBT, biofeedback, and other techniques. Then coming to the pharmacotherapy, corticosteroids has got, it is the only anti-inflammatory drug with strong evidence in CRPS, that in the acute phase. So if a patient is coming to you in that acute phase, that is 1 to 3 months of onset of CRPS, definitely you have to try steroids. But NSAIDs, even though it is they are anti-inflammatory, they have got mixed evidence. Opioids, just like in fibromyalgia and neuropathic pain, long-term use may actually worsen the condition, allodynia and hyperalgesia. So it is not recommended unless as an rescue treatment. When everything else fails, you can give a trial. Then gabapentinoids and tricyclic antidepressants, because they are first-line drugs for other neuropathic pain conditions, you can use it here also. But no definite evidence to say that one is better over other. One has a higher quality of evidence than other. These drugs you can start just like you start for any other neuropathic pain conditions. Antidepressants have this role that they will manage the associated depression and anxiety also. And we have this calcium regulating drugs, because I already told you there is periarticular osteopenia, bone resorption taking place around the joints. So you can give this calcium regulating drugs like calcitonin, alendronate, pamidronate. This also in the acute and dystrophic phase, this has got good evidence, but in the atrophic phase, it has got less evidence. Then the topical medications like lignocaine, capsaicin cream, DMSO cream, all these, if the patient is having, very localized pain, hyperalgesia, allodynia, you can try this topical medications. Lignocaine 5% patch and capsaicin has very strong evidence for which neuropathic pain, not in CRPS. Anybody still awake can answer which neuropathic pain. Lignocaine 5% patch and capsaicin also has got level 1 evidence or very strong evidence.
Post-herpetic neuralgia?
Yeah, it is very good. Post-herpetic neuralgia, PHN. Okay, it is great. It is a level 1 drug there for PHN. But unfortunately, in Kerala, 5% lignocaine patch is not available. Capsaicin cream is available. Okay.
Is lidocaine patch available outside Kerala?
Yes, it is available in elsewhere in India. In Lucknow, I used to use it, but not in Kerala. I have contacted certain company personals. They told that if you contact the personals directly, they will, they will send to the patient or something like that can be done. So
Ma'am, how many days the patch can be retained, lignocaine patch?
Lignocaine patch, I think it is for 72 hours. If I have not, 72 hours. There are different
and the onset of analgesia starts after the patch.
Yeah, within 60 minutes.
Okay.
Vineetha, I think it's 12 hours. Lignocaine patch.
Is it lignocaine patch is 12 hours? Okay. Okay. Because
you have to apply for 12 hours and then give an interval of 12 hours. That's what.
Yeah, that is what I have read. But then there are this company person who I met in the conference last time. So they were telling about this longer duration patches.
Okay.
Yeah, but what the literature says as it correct, it is correct 12 hours and then 12 hours interval and then again apply. But now this capsaicin and lignocaine, this newer patches are available, which has longer acting. But I don't know about the availability in our place. But it is also coming up. And this again infusions, ketamine has got good evidence in CRPS, and there's moderate quality evidence. And this is the usual dosage used. And for 10 days, I said there is IP protocol and OP protocol. So they have told this particular protocol to be effective. This daily for 10 days, 4 hours daily for 10 days. And they that provided improvement in pain for up to 12 weeks. That is 3 months. You can repeat after that. And lignocaine infusion, similar to the in neuropathic pain like fibromyalgia, 3 to 5 mg per kg, administered over 1 hour. It provides effective short-term pain relief, and you have to go for repeated infusions for refractory neuropathic pain conditions. So for ketamine, at least there is one guideline is there, which correctly says what should be the dose, how it should be used, which conditions it affects better, and what are the adverse effects. But for lignocaine, there is no, I didn't find any such guidelines. It is a little bit of a conflicting evidence here and there. There are some, okay, but all of you should go back and read this one for ketamine. Everybody who is practicing, CRPS, who get patients like CRPS, fibromyalgia, this first reference you should go back and read definitely. Okay. And for some interventions, CRPS, usually it is a sympathetic mediated pain. So for upper limb stellate ganglion and lower limb lumbar sympathetic flow can be tried. And spinal cord stimulation, again, not available in Kerala, but it is in Delhi, Mumbai and all. There are certain places where it is being done, Bangalore also. So if nothing else works, first they do a trial of a implant, spinal cord implant. And if that works, they will go for the permanent spinal cord stimulation. So they say that at least 60% patients get 50% benefit from spinal cord stimulation. But what is the limiting factor is the cost. It is very expensive. It takes around 1 lakh to 2 lakhs for just for the trial, and 12 lakhs to 15 lakhs for the implant, final implant. And maintenance also takes some, it is expensive. So this is an overview of the CRPS treatment. You can go back and read that when there are signs of inflammation, patient is coming to you in the acute phase, or there are predominantly the signs of inflammation like edema, redness, you go for corticosteroids. It has got good evidence. Suppose the patient is having focal osteopenia in the X-ray or triple phase bone scan, bisphosphonates and calcitonin works. Patient is having features of peripheral and central sensitization like spontaneous pain, hyperalgesia, allodynia. You should give analgesics as well as a co-analgesics, gabapentin, TCAs, topical analgesia. The patient is having significant motor symptoms like dystonia. At final stages, there will be atrophy, dystonia, then intrathecal pumps or intrathecal baclofen can be tried. And this physiotherapy, psychotherapy, that actually should be there throughout the management of CRPS from the beginning to the end. Okay. So that's it. We come to the end of CRPS also. Any doubts regarding neuropathic pain or CRPS or generally about all the 4 topics? So I'm happy I finished exactly at 9 o'clock. So anything else, if you want to discuss, you can ask.
Ma'am, just a small question.
Yeah.
Ma'am, I have recently read in an article regarding, hello?
Yes.
Ma'am, regarding the fibromyalgia, there's study going on regarding the green light, and they're using the green goggles.
Okay. Okay.
Yeah. Or have you started using that?
No. It is green light means something like we use infrared, similar to that.
Yeah. So they're using kind of goggles. They started goggles, the green color, and it's showing positive results, but a large trial is still required. And a small subset.
And one more thing I forgot to tell is caffeine. Caffeine is it is there is some evidence that it worsens the symptoms of fibromyalgia. Also, just like because I read it somewhere, and now every day I ask my patients that, are you taking a lot of coffee? So maybe you can. There is some evidence that caffeine worsens caffeinated drinks.
I have a small question. Like with chronic pain and fibromyalgia, this cortisol is suppressed, and sometimes a short course of steroid, will it help?
You're asking about fibromyalgia, right?
Yes.
Yes, in that fibromyalgia slide also I showed that there is evidence to say that ACTH decreases and growth hormone. There is some changes happening in that biochemical, hormonal disturbance, but there is no strong evidence to suggest the use of corticosteroids in fibromyalgia.
Okay.
And even that study has told that I have told in my slide I have written, even though the ACTH is dysregulated, they have found that the studies have found that there is no change in cortisol concentration. This is actually from the textbook of pain, Bonica. Okay, Bonica's textbook of pain, the latest edition, they have written this particular point that I'm talking. ACTH has been found to be dysregulated. There are changes in the concentration, but studies fail to prove that there is any change in cortisol. For that same reason, we cannot say that cortisol is effective. Cortisol supplementation is effective.
Okay. And are there any trophic changes in fibromyalgia patients also?
Pardon? Are there trophic changes? Not according to the this thing. Trophic changes are very unlikely in myofascial and fibromyalgia patients. Trophic changes mean the skin, brittle skin, mottling of skin, nail will be usually not seen.
I don't know whether they are fibromyalgia patients, but according to me, they fit in one sitting. Sometimes you will not be able to diagnose fibromyalgia, right?
Yeah.
By speaking.
See, the only way is you should, whatever you diagnose, you should have a base why you are diagnosing that. So use the ACL criteria and put the blame on them if we are not correctly diagnosing it. What else we can do? But we have an evidence, we have a documentation why we diagnose the patient as fibromyalgia or CRPS. We know we have the Budapest criteria. So for all these syndromes with a definite diagnostic criteria, take a printout of those things, keep it in your OPD, and document in your patient notes that I have used this criteria and this patient is fulfilling the criteria. That is the only way, and start management according to that. If the patient is not getting any benefit, then you have to revisit the diagnosis.
Okay.
Okay, I think we have to wind up the session. So thank you, Vineetha, for the wonderful session. So we will see Vineetha once more on coming Friday with another class on pain. And thank you, everybody. And Vineetha was very busy today. But she could find out time to be with us. Thank you, Vineetha, once again. And thank you, everybody. Now to say
Thank you, sir.
Thank you, Vineetha, ma'am. Thank you so much. And you, of course, showed that courtesy of informing us prior that you will be late to join. Thank you so much for that. That is expected from very few number of faculties. Thank you so much for that. And thank you for enlightening us. I know I can personally feel that you have had a very very stressful day, and please do take rest after this. Thank you everyone for joining, and please do remember to leave your valuable feedbacks, as I will have to mail your valuable feedbacks to Vineetha ma'am tomorrow. So we promise that we will see again in the next session with another.
Yeah, I will just add one thing. Next session, the class will not be this intense like CRPS, fibromyalgia. I know I have been bombarding you all with a lot of information all these days, but it will be just joint pain, chronic pancreatitis, like some miscellaneous, and any doubt you have in these 3 sessions, we can discuss. And I am also learning from you all, just like she told about green light. Now I was not aware of that. So there are so many things that I can also learn from you all. So we will discuss, maybe class for 45 minutes, and then we will discuss. And if you want me to tell anything specifically, you can mail me also earlier, so that I will come more prepared. If you want me to repeat any particular topic, say low back pain or sensitization, anything you want me to repeat, low back pain history taking or anything like that, just inform Sri Priya, so that I will come prepared with the slides and all. Okay.
Thank you, everyone. Stay
Thank
safe,
you.
be happy, keep spreading happiness. Bye-bye.